Hi, my name is John Faragon, and I'm a pharmacist at Albany Medical Center Hospital in Albany, New York, and I'm also the Regional Pharmacy Director for the Northeast Caribbean AIDS Education and Training Center. I'd like to welcome you here today. We're going to be doing these mini modules this year with the ATC, and this is one of a few of them that we've actually have on our website for you to take a look at. These are meant to be really quick modules just on basic topics centered around antiretroviral therapy and the treatment of HIV infection. So this one we're going to talk about our preferred regimens on DHHS guidelines for 2017. So the guidelines are very helpful, help us to inform us what we should do for patients who are infected with HIV. And what I'm going to focus on today on the DHHS guidelines is basically what regimen to start based on the most recent version of the guidelines. So basically, there was a big push, I think, in the guidelines to move towards integrase-based regimens. And both the DHHS guidelines and even the IAS-USA, which is the International Antiviral Society, have really went towards integrase inhibitor-based regimens. And the ones that are preferred now, there's one of basically 5 different regimens that are listed here. And the first one is dolutegravir, abacavir, lamivudine. And I'll talk a little bit about the brand names in the next slide for those patients who are HLA-B5701 negative. You can also use dolutegravir plus either tenofovir disoproxil fumarate with emtricitabine or tenofovir alafenamide plus emtricitabine, and those are on the guidelines. Elvitegravir Cobi, tenofovir alafenamide, emtricitabine. Then we have elvitegravir Cobi, tenofovir disoproxil fumarate, emtricitabine as well. And then finally, raltegravir plus either tenofovir disoproxil fumarate, emtricitabine, or tenofovir alafenamide, emtricitabine. All right, again, a lot of name soup, right? But in the next slides, hopefully I'll give you some of the brand names, and then hopefully it'll help you to kind of solidify the meds. On DHHS, there's also a protease inhibitor-based regimen, which is darunavir, ritonavir, plus either TDF, emtricitabine, or TAF, FTC. And again, we'll talk about the differences between TDF and TAF in a few minutes. But again, know that basically the integrase inhibitors for treatment-naive patients really it's really where the guidelines have pushed. So protease inhibitor-based regimens, if you are starting a PI, those are going to be mostly in patients who have really unpredictable adherence. That's a great place to use a boosted protease inhibitor. And the only one that's on the guidelines right now is darunavir, ritonavir. You'll notice that darunavir with cobicistat is actually not on the guidelines as a recommended regimen. It's actually an alternative regimen, but again, it's still on there as a potential option as an alternative, but not on the current recommended list of regimens for DHHS. So this slide actually gives you on the left-hand side the generic names, which we just kind of talked about, but on the right-hand side it gives you the brand names. And again, there's always a back and forth about putting brand names in presentations, but I think the brand names really do help you know what drugs we're talking about. Most people are using brand names when they're talking about the meds, and especially if you don't have a lot of patients and you're not familiar with the medications, I think the brand names really help. So the only PI-based regimen that's on the guidelines right now would be prosistanorvir plus Truvada or prosistanorvir plus with Descovy. So you're going to see in this presentation that Descovy and Truvada are both on the guidelines as options and are recommended now, right? So some guidelines, for example, the IAS-USA only went with Descovy-based regimens or TAF-based regimens. But here in the DHHS guidelines, you have the option of using both Truvada or Descovy. So for integrase-based regimens, if you're HLA-B5701 negative, you can use Triumec, which is a combination of dolutegravir, abacavir, and lamivudine. So the abacavir is the piece where you have to do that HLA testing. So if patients have HLA-B5701 positive, those are the patients that are going to be more likely to have an adverse event with abacavir and potentially that hypersensitivity reaction that can be fatal in some patients. So that HLA really is crucial if you're going to use abacavir-containing regimens. Dolutegravir separately, though, which is the brand name Tivicay, can be used with either Truvada or Descovy as an option as well for integrase-based regimens. And then both Stribild and Genvoya, which is basically boosted elvitegravir with either TDF or TAF, is on the guidelines as well. So Stribild or Genvoya. And then finally, raltegravir with either Truvada or Descovy. So Isentress Truvada or Isentress Descovy is also on the guidelines. So in summary, what the DHHS guidelines really have done, they've left a boosted PI plus either Truvada or Descovy, And then they have basically every single integrase inhibitor that's on the market today is on the guidelines as an option to use in combination with either Truvada or Descovy. The exception only here is with Triumec, which actually that contains abacavir, not tenofovir or TAF. So abacavir is the difference there with the Triumec, and then the lamivudine is different as well. All right, so basically all of your integrase-based regimens are now recommended on the DHHS guidelines. So just really one quick, we kind of alluded to this, but TAF is contained in Descovy, Odefsey, and Genvoya. And again, TAF is the prodrug, is a drug that's a little bit different than TDF, okay? So tenofovir alafenamide basically provides you with levels of tenofovir in the plasma that are much lower than what we got with TDF. So the bottom line that where this drug is believed to be an advantage, you get less proteinuria with TAF, and there is suggestions that there's even less bone toxicity with TAF. So many of our providers at Albany Med, not everybody, but some of our providers have moved kind of to this TAF formulation. So that's where the guidelines also went to. They actually kept TAF or TDF on the guidelines. Both of them are listed there, but TAF is still an option, which I think is a good thing. Because especially in patients with creatinine clearances that are closer to 30, you can still get away with using TAF where you can't use TDF. So again, the renal benefits and the bone benefits, I think, are really the driver for why TAF was added to the DHHS guidelines. And so if we look at the individual regimens themselves, let's talk a little bit first about Tivicay plus Truvada or Descovy or Triumec, all right? So these are basically dolutegravir-based regimens that are recommended on the guidelines. So adverse events that occurred greater than 2% were insomnia and headache. There have been renal and bone side effects, obviously, with tenofovir DF, the TDF, but TAF it's less likely. There's been some hypersensitivity reactions that have been associated with abacavir, so that's a big concern if you're going to use Triumec. You can get a flu-like illness, you can get rash, fever, constitutional symptoms, and that's clearly related to the HLA B57001. So if you have that B57001 and it's negative, you're not going to have this hypersensitivity reaction occurring. But again, at the most, you wind up on 2, but potentially 1 pill if you just use the Triumec. But again, 2 pills a day max is the pill burden with this regimen. So Stribild has been out for many years now, and this is basically elvitegravir, so it's an integrase that's boosted with cobicistat plus TDF plus FTC. So it's basically a single tablet regimen, or 1 pill, once daily, complete regimen in 1 tablet. There are some GI side effects from cobicistat. There's this issue with tubular secretion blocking that can happen with cobicistat as well, which sometimes will raise people's creatinine from baseline. And we manage that by basically trying to determine whether or not it's the TDF or the cobicistat. If it's less than a 0.3, 0.4 mg per deciliter change, it's normally going to be from the cobicistat. Renal and bone side effects are possible with tenofovir DF. And then obviously there's some drug-drug interactions for cobicistat that are actually very similar to ritonavir. So if you're using a boosted PI, boosted protease inhibitor, and you're used to using ritonavir, the cobicistat interactions are almost identical with Stribild than what you see with a boosted PI. So for Genvoya, this is the 1 pill once a day elvitegravir Cobi, but it has TAF instead of TDF. So in this, you have TAF replacing TDF in the Genvoya. So there's less proteinuria, better bone profile, and again, the drug-drug interactions would be very similar. So really this Genvoya and Stribild, the only difference is really TDF in the Stribild and then TAF in the Genvoya. So again, a lot of providers have switched to Genvoya. You don't have to switch if there's no reason to. But again, if somebody has osteopenia, osteoporosis, or if somebody has renal side effects from TDF, you could potentially get away with using TAF in those patients. Okay, so that's really the key point with that one. So the last integrase inhibitor that I'll talk about in this section is Icentris plus Truvada or Icentris plus Descovy, and these are some key points with this one. This is a 3-tablet daily regimen. The Icentris is dosed twice a day, once daily dosing. Although it's possible with this formulation, it is inferior to the BID. The Icentris now is available in an HD. It's called Icentris HD formulation, which again is not on this slide, but it's a 2 600 milligram tablets once a day. So there actually is a once a day formulation of Icentrus that was recently approved by the FDA and is likely to be available at some point. Well tolerated, no effect on lipids. Renal side effects are possible with the DF formulation, but it's less if you're using TAF. So this is one of the drugs that we use for post-exposure prophylaxis. We use Icentrus plus Truvada in our post-exposure protocols that we have at Albany Med. And I think a lot of providers, a lot of places do use that regimen. Again, it's very well tolerated. There are some potential drug interactions with magnesium and aluminum-containing antacids, which sometimes make it a little bit complex. But again, I encourage you to take a look at the Icentrus HD for once-a-day dosing. But again, this is the 400 milligram BID formulation that we're talking about here. And so the next one we'll talk a little bit about is Persista Norvir Truvada or Descovy. So this is the only boosted PI that's actually on the DHHS guidelines. It's a 3-tablet once daily regimen, so you can either take this with 800 of Persista plus 100 of Norvir, or you can take that with either Truvada or Descovy. It's a boosted PI regimen, meaning that when you boost the protease inhibitors, you get less resistance in that class, and that's been shown in many studies. It's dosed once a day with food. There are potential GI side effects, but it has a minimal effect on lipids. Again, because you're only using that low dose of ritonavir is probably a big reason why that's the case. It does have a sulfa moiety, so be careful of patients with severe sulfa allergies. And then there are some renal side effects with tenofovir DF, but it's less likely with TAF. The most important piece on this slide is what's not here, and that's the fact that Prescobix, which is Persista plus cobicistat, is not preferred on the DHHS guidelines. It's actually an alternative regimen, although some people may use that in its place. But again, it's not preferred or not recommended it's an alternative on the guidelines, not a preferred regimen. And then finally, at the end here, you can see darunavir Cobi TAF FTC is in development. And we'll have to see how that pans out, but that's in development as a single tablet regimen. So you'd have basically Descovy, Prescobix, basically in a 1 pill once a day option, which is being developed. And then finally, kind of round this section out, I think there's a couple slides here. We'll talk a little bit about ritonavir, cobicistat boosted PIs. Just be careful of some of the drug interactions. There is lower pill burdens, but again, you got to be careful about drug interactions when you have patients on either of these meds, because they are a real issue when it comes to using these medications. And then just a couple comments on pill burden. So we hear this a lot about pill burdens and what we're going to do. And people come into the clinic all the time and they want a 1 pill once a day option. And I can just tell you that this is the recommendations from 2016. They haven't changed for this year. Tivicay, Truvada, or Descovy, or Triumec. Some of these wind up being 1 pill once a day options. Some of them wind up being 2 pills. But really, regardless of what you pick, if patients take it and they're treatment naive and they don't have resistance, they really will do fine. As long as they take it every day and they don't miss doses, they really will do okay. So I encourage you to make sure that patients are taking what they're supposed to take. And then again, looking at pill burdens of some of these regimens listed here. And then finally, this is the last slide, just looking again at pill burdens. The worst case scenario, you wind up on 3 pills once a day. So again, there's a lot of different options for us, but here, even 3 pills. So Persista Norvir, Truvada, or Descovy, 3 a day. Icentrus, Truvada, 3 pills a day. It really makes it a lot. It's not that bad from a pill burden perspective. But these people are patients that come in sometimes and they want a 1 pill once a day option. It's not always possible for everybody, but a lot of times it is. And I think that's really the point here. And so again, I'd like to thank you very much for taking your time today to listen to this module. This is basically the preferred guidelines on DHHS guidelines of what to start as initial treatment regimens for antiretroviral therapy. I certainly haven't covered every single side effect, and I certainly didn't cover any of the drug interactions, but just know that these are the basics of ARV therapy. When you're trying to figure out what you should be using up front, this is what the most current guidelines from DHHS recommend. And I thank you for you taking your time to listen to this module today.